afternoon, everyone. Welcome back for our closing keynote speech of the 2022 Montana Housing Partnership Conference. It's been such a wonderful 2 days together. Hope everyone has enjoyed your time in these sessions, and I couldn't be more excited about how we're closing out the conference this year. I want to first recognize our closing plenary sponsor, which is the Richmond Group. So thank you to the Richmond Group for their support. And I'd now like to welcome Ted Madden, Chief Operating Officer of the Montana Healthcare Foundation, to say a few words and introduce our keynote speaker. Thanks, Ted.
Thank you, Kaya. Thank you, Kaya. I know we've spoken at these last few conferences, and a lot of the participants are involved with our Housing as Healthcare work at the Montana Healthcare Foundation. And again, this would be a great keynote to highlight that work, especially now more than ever with all the stressors going on in folks' lives and the importance of the social determinants of health. And our CEO, Aaron Wernham, really made this connection early on in the foundation's life cycle, that as a health foundation, we're not going to really move the needle on a lot of health issues unless we deal with the social determinants of health and address those. And so many of you know we do our Housing as Healthcare initiative in the 7 biggest communities, really focusing on the most vulnerable of those communities, the chronically homeless that are high utilizers of social service, emergency, and criminal justice systems, to really make an intentional effort to connect housing availability on a housing first basis with health services. But beyond that, we work in our rural communities, really trying to connect the dots between health systems and housing. And we do some work with our tribal partners as well on needs assessments and other planning grants with housing. So it's exciting today to really connect some of those dots. We do that both at the local level and at the department level too. We're close allies with Department of Health and Human Services and their Medicaid department and other departments there. The State Continuum of Care, David O'Leary, and formerly Bob Buzzis, and also with the Department of Housing. Really, in any way possible, connect systems between health and housing, knowing that housing is a social determinant of health. That's why it's exciting to welcome Megan Sandel, MD, MPH at the Grow Clinic at Boston Medical Center. She's been working on these issues, especially around children and the social determinants of health with children and the connection to housing through her work at the Grow Clinic at Boston Medical Center. She's also the co-lead principal investigator with Children's HealthWatch and associate professor of pediatrics at Boston University Schools of Medicine and Public Health. So we have this well-known East Coaster coming to Montana. And so she's had some real practical experience being a pediatric medical director at Boston Healthcare for the homeless. And she is nationally recognized as an expert on housing and child health. In 1998, she published with other doctors at Boston Medical Center the Doc for Kids report, a national report on how housing affected child health, the first of its kind. Over the course of her career, Dr. Sandel has written numerous peer-reviewed scientific articles on the subject. In 2001, she became the first medical director of the founding site for Medical Legal Partnerships, Medical Legal Partnerships Boston, and from 2007 to 2016, she served as the medical director of the National Center for Medical Legal Partnerships. So she has fingerprints all over social determinants of health as a MD. She served as principal investigator for numerous National Institute of Health, HUD, and foundation grants, working with the Boston Public Health Commission and Massachusetts Department of Public Health to improve the health of vulnerable children, particularly with asthma. She has served on national boards, including Enterprise Community Partners, which a lot of us know as a great partner out there in the housing world, and national advisory committees at the American Academy of Pediatrics. So there's a lot there. We welcome her. We want to give her a nice, warm Montana welcome. Let her know that there's a lot happening in Montana around this subject, but there's a lot more to learn. And we look forward to her presentation and perspective. Dr. Sandel.
Great. Well, first of all, just thank you so much for having me. My best friend lives in Montana. I have had the pleasure of coming to Montana many times, and in many ways, my thoughts are with many Montanans today because of my friend is from Red Lodge, and the Red Lodge area and that southwestern part has been suffering terrible flooding. And I just want to send my deep thoughts and well wishes to people who are dealing with a lot. And I think in many ways, those are the situations where you connect housing and health, right? And I think my hope today is to be able to talk a bit about how I really view, and I think many view, how stable, decent, affordable homes are really the foundation of health for children, families, and communities. If we go to the next slide, I just want to give a bit of kind of a roadmap for how I'm going to lay out the talk today. In a lot of ways, I like to first lay out just a couple of general slides. So I'm going to do about 3 slides of just kind of general framing for the talk itself, and then go into what I consider to be the 4 dimensions or the 4 walls of which how homes affect health. And I'll talk about quality, I'll talk about stability, I'll talk about affordability, and I'll talk about location. And in that, I really hope to be able to really talk a lot about how do home and place really result in concentrating of inequity, okay? I then want to talk about upstream solutions, because I think the good news is we know how to create stable, decent, affordable homes. And I think in many ways, what I was really excited to be asked to come to Montana virtually this time around, being able to talk about how to put those things together, because I think you have all the essential ingredients to creating stable, decent, affordable homes. And then I'll give you at the end just some lessons learned of how I've over the last decades seen how do housing and health partnerships really work in terms of across sectors, and how do you build them together for the future. So let's get started. The next slide, I want to just give a little bit of an overview of a concept that I consider to be really essential, which is this concept of structural competency. And where that comes in is really this: to understand how housing and health are connected, you really have to understand how do structures, systems, social hierarchies like racism come into how we see differences in social determinants of health. Those can be rooted in poverty, but they also can be rooted in other forms of inequality. And that those then social factors drive oftentimes many of the health outcome differences that we see. And so I'm a big fan of this concept of structural competency. Jordan Metzel and Elena Hansen have written a bunch of articles about it, but I want you to start to think about, as I'm talking about these frames, I want you to think about what are the policies and economic systems and social hierarchies that drive these social differences, and how do we start to see those then play out in health outcomes. And I want to give a shout out to my friend, Dr. Renee Boynton-Jarrett, who founded the Vital Village Network. She's the one who first brought this structural competency framework to my attention. If you go to the next slide, I think more and more we are deeply understanding what are called social determinants of health now. And I think first and foremost, I think it's really important to understand that social factors as they're related to health are not organic, but they're actually designed. And so if we think about kind of the outcomes that we're getting from the current system, they are the outcomes the system is designed to get. And so what I joke about is 20 years ago, most of the talk that I had to give was connecting the dots about how housing and health were connected. And most people now see it. They understand that housing and health are connected. Now we're at the stage where how deeply do we understand that they're connected, and how do we start to actually create more decent, affordable homes so that everyone has that same fair shot. I think where we think about social determinants of health, I sometimes will say is, I work as a pediatrician, and we often will say things like, oh, that patient has social determinants of health, and we don't mean it in a positive way. And what I tend to say is everyone has social determinants of health, just some of us have better social determinants of health than others. So I like to say my children have spectacular social determinants. They have two parents that are doctors. We live in a house that we own. We're in a great school district. We live near a park. We live in a safe part of the neighborhoods. And so what are the ways in which that happens? And so I think it's really important to keep in mind that social factors can be both asset-based and deficit-oriented. So sometimes you have, if you're living in a certain community and that's where your church is, that's a positive social factor that's going to drive your health outcomes, as much as it may be negative that there may be not a great grocery store in your neighborhood. So it's really important for us to think about them as both asset and deficit. I think the other piece is that oftentimes we isolate them. We just talk about housing when we have to also think about jobs, and we have to think about transportation access, and we have to think about ways in which there may be a grocery store. And so as we start to think about it, they are multifactorial, they are interactive. And in many ways, again, they're not random. So things like structural racism and oppression do really dictate whose social factors are better than others. So if you go to the next slide, the last of my kind of framing parts is really this understanding that housing is a foundational social factor. And so those that are familiar with this pyramid called Maslow's hierarchy, we understand more and more that in order to be successful, we have to be able to address our physiologic needs, things like food security, and our safety needs, things like housing stability. And so as we say, I don't like to say that some social determinants are more important than others, but I do think we have to understand foundationally, nothing works very well if you don't have a stable, decent, affordable home. Healthcare doesn't work very well. Education doesn't work very well. Community safety doesn't work very well. And so what are the ways in which we can now see all of us together in making sure that we have food secure, housing stable communities, and how we all benefit from that so that everyone can reach their actual potential. So if we go to the next slide, I like to give kind of this overview of these dimensions of how housing and health are connected. And one of my favorite articles is by Lauren Taylor in Health Affairs from a few years ago, where she kind of bucketed into 4 major categories: stability, quality safety, affordability, and kind of neighborhood and community. So those are like the key places that I'm going to talk today about how housing and health are connected. I could give a full conference on all of these. So I'm going to give just some highlights in each of these areas just to kind of continue to think about it. And as you're thinking about this, hopefully after I finish talking and you're reflecting on the talk, remembering these 4 categories, because oftentimes they are the most important ways in which housing impacts health. So if you go to the next slide, I like to say the evidence on how home quality impacts health is decades, if not centuries old. I actually start with accidents and injuries. And the reason for that is oftentimes people don't necessarily realize that once you take away motor vehicle accidents, the leading cause of death for kids are home-related injuries, fires, drownings, things like that. And then if you think about beyond childhood, if you think about elders, the risk of falls and other things are incredibly important. And so I always like to start with safety first. Home quality, thinking about accidents and injuries become critically important in terms of how we think about how home quality impacts health. I first got really interested in how housing impacted health through asthma. I was a new intern learning to be a pediatrician, and I admitted a child to the ICU with asthma. And I asked kind of a fateful question of what had changed. And the family started talking about the fact they had gotten a cat. Now, if we were all together, I would ask the audience, I would say, why did the family get the cat? And what you would answer is maybe because they had mice. And you would be right, that in a lot of ways, what ends up happening is that families make these choices. They weren't able to get the landlord to fix the housing, to get the mice exterminated. So they got a cat. Turned out the daughter was allergic to cats. And so she ended up in the ICU. And so these are the ways in which I really started to think a lot about what were ways in which asthma was tied to, and more specifically, housing conditions were the underlying reason why kids became sick. Obviously, we understand now about pests, whether they be in urban settings, cockroaches, or more rural settings, mice. but also things like chronic dampness and molds, or even tobacco smoke. One of the things people may not realize is that when kids are exposed to smoke, 86% of the time, it tends to be in the home setting. And so what are the ways in which we start thinking about smoke-free housing policies? Lead is an ongoing issue, not just often from lead in paint, but also sometimes now lead in water pipes and things, and seeing those developmental delays. And then lastly, I think it's really important to talk about heat or eat, this idea of weatherization, and how is a home quality potentially not going to be very energy efficient, and how does that impact your long-term health? And so this concept of sometimes you're paying a lot for heating and therefore you're having to make sacrifices or heat or eat. If you look to the next slide, one of the ways in which I think people sometimes miss is the connection between home quality and mental health. Thank you. And so one of this is a really great article from a series that's funded by the MacArthur Foundation called How Housing Matters. And if you actually go to housingmatters.org, the Urban Institute continues to curate this amazing library of ways in which housing and health are connected. But this was a study that was done in 3 different cities across the country, and they actually showed that housing quality was actually the strongest predictor of emotional and behavioral problems for low-income children, and that much of the association of that poor housing quality traveled through child well-being and, frankly, parental stress and parenting behaviors impacting the kid. So think about that. The kid lives in a home that is not of great quality. The kid is stressed out. They carry that to the school environment and they act out at school. And so you start to understand that it really is this mental health, this child development, that is as important to what home quality means as breathing and other types of toxic exposure. So I always like to say that home quality is a physical health and a mental health issue. It also is something that affects the entire household. It's not just a kid issue or other. So as we think about housing quality, right? Now let's talk about stability. And I like to think about it like an iceberg. If you click next, we'll talk about homelessness. And what we often will say is homelessness is part of the iceberg you can see, but there's a lot of iceberg below the surface. If you click again, I think it's really important to think about homelessness and housing instability. And if you click again, these forms of housing instability, moving frequently, falling behind on rent. And if you do one more click, the root cause of this is often unaffordable housing. And so as we think about these issues, right, oftentimes we focus a lot on the part of the problem we can see, the part of the iceberg, the homeless problem, but we oftentimes will not focus on the part that's below the surface, the part that may be hidden to our eye. People who are having to move frequently, maybe they're sleeping in a living room, or they're doubled up in a bedroom, or they're falling behind on rent and having to make really toxic choices. And so that root cause oftentimes is unaffordable housing. If you go to the next slide, we at Children's HealthWatch is a research policy network. If you're not familiar with it, it's a national research policy network based out of Boston Medical Center. And what we end up studying is the impact of common economic hardships, food insecurity, housing instability, energy insecurity on the health and development of young kids 0 to 4. And we've been in existence since 1998. We've interviewed over 75,000 families in urban settings like Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis. And what's important is, if you go to the next slide, we've started to really look at homelessness matters. And it matters in a lot of different ways. It's an independent risk factor to birth outcomes, and how having a much higher risk, if you're homeless, of a premature baby or a baby that's low birth weight. We also will see oftentimes that the first year of life, a critical time of which to grow, that we see homelessness as a really important factor in infant health and maternal health and hardship outcomes. And finally, I think it's important to keep in mind that sometimes homelessness and the effects will stay with you even after you are housed. And so we were able to show that the timing and the duration of homelessness impacted kids even after they were born and after they became housed. So this is what's really important, is to keep in mind, we need to prevent homelessness as much as possible. But let's dig deeper on the iceberg. If you go to the next slide, you'll see that we have actually seen that if you can prevent homelessness, there may be associated healthcare cost savings. So we estimate that each year, and this is honestly a couple years old, we published this research brief with the National Housing Conference in 2015, and we showed that there were over $200 million of healthcare costs related to child homelessness in children less than 12 months of age and up to age 4. So this is just the tip of the iceberg of how we are starting to pay for not averting homelessness in these critical time windows. If you go to the next slide, we started to dig in more on ways in which these different forms of housing instability could manifest itself. And so we actually studied among 22,000 different families over a 5-year period. We looked at renter families and we asked them about 3 different forms of housing instability. We asked them about whether they had been behind on rent in the past year. We asked them about whether or not they had moved frequently. So we said, how many places have you lived in the past year? And if they said 3 or more, that meant that they had moved at least twice. And we asked whether or not they had been either currently homeless or been homeless in the child's young life. And what we ended up seeing was this really interesting pattern. Each of these was associated with adverse health. I will note, we also asked about overcrowding, and overcrowding actually wasn't associated with adverse health, at least in our sample. So next, go to the next slide. Is what you can see is actually that there is this interesting lack of overlap. When we look at the 3 different patterns, behind on rent, being homeless in the child's young life, or multiple moves, what you'll see is actually these are distinct populations. That people who become homeless typically are different from people who fall behind on rent, are typically different from people who may move frequently. And so it kind of gave us a bigger picture that we have to look at all 3 forms of housing instability. If you were positive for one form, 86% of the time you were only positive for one form. And then the most common form was this being behind on rent. But I think if you go to the next slide, the thing that really kind of shocked us the most was when we started to look at the different adjusted odds ratios of different outcomes, right? And so what you can see in the red bar is that those are people who are stably housed, right? They don't have any history of homelessness. They're not behind on rent. They're not moving frequently. But as you start to look at the behind on rent group in the purple bar, or the multiple moves group in the green bar, or the family that had a history of homelessness or currently homeless in the yellow bar, I think we knew that homelessness was bad for kids' health, right? I showed you some of those research previously, but what you'll see that shocked us was that purple bar, right? We're seeing now, 50% increased risks of child being fair or poor health, 100% risk of maternal and fair or poor health, twice as likely to be maternally depressed, high rates, 3 or 4-fold food insecurity or healthcare cost trade-offs. And I think we knew that homelessness was bad, but we didn't know that being behind on rent was just as bad for kids and mental health. And so as we start to think about this, I think it's really important for us to not just think about ending homelessness in communities. We have to be thinking about ending behind on rent in communities if we are going to achieve our biggest health impacts over time. So if you go to the next slide, one of the things that I wanted to emphasize is that study that I just showed you was pre-pandemic. We published that research on the effects of behind on rent in 2018. And what we know is that there has been huge amounts of increased housing instability during the COVID-19 pandemic. In this case, over 1 in 7 of renters reported not being caught up on rent, and that renters of color are facing often the greatest hardships. I will note that there's difference by different race category. And so one of the things that I do want to note is the Pulse survey that this is from will categorize in that other multiracial, not Latino category. That is where American Indian, Alaskan Native, Native Hawaiian, and Pacific Islanders, and people who identify as more than one race is often in that category. So I think it's important to note that because I know that is a really meaningful population in Montana. And what you're seeing is that families with children are even at higher risk. 1 in 5 of renters with children are not caught up on rent. And so this is really emphasizing, we showed you pre-pandemic that falling behind on rent was really important to health. And now we have a COVID-19 pandemic that's making that even more important as we think about rapid responses. If you go to the next slide, one of the things I wanted to talk about lastly is place. And as we think about communities and honestly segregation in communities, I wanted to point you to a really cool tool that is developed out of Brandeis University, diversitydatakids.org. And what's exciting about diversitydatakids.org is that it actually has mapped through this index called the Child Opportunity Index. It actually has mapped every census tract across the country, including all the census tracts in Montana. And so if you go to the next slide, what is in the Child Opportunity Index? And what it is a really cool index that was developed at Ohio State out of the Kirwan Institute. And what it does is it takes 17 different factors, right? Student poverty rate, school quality, early childhood education, graduation rate. So it has a whole educational opportunity section. It has a health and physical environment section, and it has a social economic opportunity section. And so what it will do is then grade these communities by census tract according to an index that goes from very high, which is the darkest, down to very low, which is the lightest, okay? And so what you'll see here is the metropolitan area in Atlanta. And then if you go to the next slide, what we know though is that opportunity often is not a necessarily race neutral. And so what we end up seeing here, and this is what's cool, is that you can map onto the maps different racial categories. So in this case, you can see the blue dots illustrate non-Hispanic white children. And they often, as you can see, are in higher opportunity neighborhoods. If you click to the next slide, what you'll see is the overlay of where more non-Hispanic Black children live in urban areas. And what you can see is there in the lower opportunity neighborhoods is where those kids are more concentrated. And honestly, I could pull up the similar map and I could show you where the Crow Reservation is, and I can show you where Bozeman, Montana is, and I can show you similar differences in terms of opportunity and where different categories are. If you go to the next slide, I'm going to show you a map of the city of Boston. And what this is you can see that it's the similar maps, right, where you have some of the more concentrated opportunity neighborhoods in the downtown area, or in a town adjacent to Boston called Brookline, which you can see that kind of really dark red area to the left-hand side is where Brookline is. And then you can see the central core city where there's low opportunity neighborhoods, and that's where predominantly people of color in the city of Boston live. Again, one of my colleagues, Dr. Renee Boynton-Jarrett, she founded a network called the Vital Village Network, and we partnered on a paper in Academic Pediatrics where we actually took the blood pressure readings of 3-year-old kids, and we actually mapped to the prevalence of an elevated blood pressure at age 3. So the bigger the circle here is the higher the prevalence of being above the 95th percentile for blood pressure by age. And what you start to see is where the social and the biologic start to meet, right? You're seeing where there's a higher prevalence of high blood pressure in low opportunity neighborhoods, and frankly, low opportunity neighborhoods that are next to high opportunity neighborhoods. So you start to think about, how are we trying to operationalize how stable, decent, affordable homes are the foundation for health? And that means that they have to be stable, they have to be of good quality, they have to be affordable, and they have to be in communities of opportunity. And so these are the ways in which we're starting to think about this. I want you to keep in mind, you see that little red cutout, because I'm going to show you 2 more maps as we think about how this plays out. So the next map is that this is how we're seeing it play out in terms of even something as simple as COVID infection rates, right? We're seeing how economics, social, and biologic factors all meet together. This same map of the city of Boston, where you see that central core city, which is low opportunity is also where more people pay more of their household income towards rent. It's also where there's a higher rate of unemployment, and it's a higher rate of where there were COVID-19 infections. So these deep-rooted inequities are really important. And if you go to the last slide, the next slide, you'll see also that these are the maps from the 1930s, where the federal government decided on who warranted getting better mortgages. Where were mortgages for people of color that could be approved, and where were mortgages where people of color couldn't be approved? And so you see these red-lined maps. And again, that central core city is the same, that low opportunity neighborhood is the same one in red here on this map. And then you can see the cutout where that neighborhood of Brookline, that town of Brookline is, where it was green and blue predominantly, that was approved, where people could buy mortgages. And so as we think about this kind of the systems, the hierarchies, the policies, how those have now played out in different social determinants of health, and how those continue to now play out in health inequities, we have to be as intentional in undesigning that system as it was designed to get the outcomes that we have today. So I'm going to go to the next slide, and I'm going to start to shift gears, because in many ways, I talk about this as we often spend a lot of time downstream, where there is disease and injury, and trying to solve those problems, especially in the healthcare world. That's where we spend the majority of our time intervening clinically and screening for social determinants and trying to impact them. And what I'm challenging you today is to think about not just doing the downstream work, but can you go upstream? Can you work with populations, marginalized populations and others, and work geographically to address social determinants of health through multi-level interventions? This is ways in which you can start to address things in much deeper ways that became a huge difference. So if you go to the next slide, I think it's really important to start to think about some of these examples. So I'm going to give you an example from Medical Legal Partnership, and I want to give a shout out. Montana has a health justice partnership, that is a housing justice partnership, that is focused on particularly addressing many of these issues around medical legal partnership, where you're starting to branch together healthcare, legal aid, and public health. So if you go to the next slide, this is from Cincinnati Children's, and they have really implemented the medical legal partnership approach, where you can identify issues, you can transform clinical practice, and ultimately you can get to population health. And so I want to share some examples from them. So if you go to the next slide, you'll see that there's a letter that one of their patients brought to clinic that said, at this time, all residents are not permitted to put air conditioning units in their apartments, and anyone with an air conditioning unit will be evicted immediately. And so what was interesting is the doctor was like, that seems kind of not right. So let me send you down to the lawyer. And what was interesting is that a different doctor got a different letter from a different patient the next day. And so they said, wait a minute, what's going on here? And so if you go to the next slide, they started to map where all of their legal cases were. And so the medical legal partnership in Cincinnati is called the HELP program, Health Law Program. And so you can see the location of the child help cases. And then they started to look to a certain landlord. And it turned out that a certain landlord was the predominant landlord for a lot of their cases. And so what was interesting is that landlord had accepted HUD money and was not keeping those buildings up to code. And so if you go to the next slide, they were actually able, if you can believe it, go do 2 more clicks, 1 more, that's it. So, oh, sorry, go back 1. So what you can see here is they actually forced the sale of the building to the community builders, and the community builders were actually able to fix the roof, and they were actually able to start to do better. And this was actually published in Pediatrics, identifying and treating a substandard housing cluster using a medical legal partnership. And so this is a way that you started to align sectors, right? Health, public health, and legal aid working together to make houses healthier, predominantly in a prevention model, not waiting till kids are sick, but actually fixing the roof before it started. So if you go to the next slide, they then said, well, we want to look at neighborhoods that are having issues. If you click 1 more, what they saw was differences in health outcomes. In certain neighborhoods, they had really low rates of kids being admitted, only 18 kids being admitted out of 29,000. That's the the right-hand side. But if you look at the left-hand side, they actually saw close to 300 kids being admitted out of only 17,900. So much higher rates. So they said, what's going on in these neighborhoods? Why are we seeing these differences? And so they looked at one particular neighborhood. If you go to the next slide, the Avondale neighborhood, and they were able to show, if you click one more, that there was a heat map where they started to show building code violations, things that were against the law, that were health and safety violations, and they showed much higher rates of it. And they said, this is kind of crazy. This is a community level factor where we're seeing higher rates of buildings not being up to code. Let's see how it predicts whether or not kids come back to the emergency room. And so if you go to the next slide, what's interesting is they tracked kids coming back to the emergency room, and they found that the heat map predicted whether a kid was going to come back to the ED a second time with a emergency asthma exacerbation. And so think about that, right? They were able to use data, and they tracked a pattern, a community level pattern by collating individual cases and seeing what was happening. And then they tracked a community pattern, and they were able to bring it down to risk factors on the individual level. And what's really exciting is they focused on that neighborhood, and they actually started to see reductions in asthma hospitalizations because they took a neighborhood level approach, not just an individual level approach. So I think as we think about these communities coming together, whether rural or urban, there are ways in which you can actually see health outcomes when you put together the data on multiple levels. So when you go to the next slide, I think what's really exciting is that there are other examples of this in the asthma world, things like where you can take weatherization and health outcomes and marry them together. So this was a study where they were able to see a 71% decline in poorly controlled asthma, where the one group just got asthma home education and just how to make the home better. The other one actually got the moisture controls, the carpet removal, the weatherizations, and they were able to see a much bigger improvement. And so you think about all the people that may be coming into a home, what are the ways in which you can do one stop? You can be able to make a home healthier and more energy efficient at the same time and tap into new funding sources over time. So if you go to the next slide, I think this is where we're going to start talking about, these are the multi-pronged solutions. These are things that we can get together and be able to start to put into implementation. I think I say these are the three legs of the stool, the things that which we can make better. We need capital, particularly for more housing production. We've not been able to build enough housing to meet our population needs. In the middle is really thinking about ways in which to help people with incomes and community development. Are there rental assistance? Are there income boosting policies? Ways in which people can get higher paying jobs or tax credits? What are ways in which we can do community development financing? And then lastly, are there ways in which people can get the tailored services to meet their families or individual needs? So this is really the model. This is how we put it into action. If you go to the next slide, we were able to test this out in Boston in a model where we were able to serve medically complex families with a multi-tiered intervention. And this is something that really every community, I think, could put together. We were able to take a health system, the health system I work at, Boston Medical Center. We partnered with researchers, part of our Children's HealthWatch research network. We worked with a housing service agency, a housing stabilization support group called Project Hope. We worked with a local public housing authority, Boston Housing Authority, which had affordable housing apartments, and we were able to do financial coaching with families through a local community development corporation. And we were able to find families who were experiencing housing instability, where somebody in the house was medically complex, and they were already using public resources through Medicaid. And so if you go to the next slide, what's really amazing is that we tested this through a model called a randomized controlled trial. This is how we test medications, where we flip a coin and we say, you get the pill and you get what's called a placebo, or basically a sugar pill. And so what was cool here is that we said half of the families we served got the housing intervention, where they were able to get an affordable housing apartment, housing coaching, financial coaching, and half of the families got a curated resource list that said, call as many places as you can, which is frankly what we do right now. And what was exciting is after 6 months, we saw the families that got the housing prescription intervention were already seeing improvements in their child health They were 32% less likely to be rated in fair or poor health. And the parents were scoring a full point less on a scale of 1 to 6. They were already scoring lower on a generalized anxiety score and a depression score. So think about that. Even just after 6 months, you saw kid health improved and parental mental health improve. And so this is what's exciting. And we published this in Health Affairs as an example of how you put this stuff together. If you go to the next slide, I think that we're thinking a lot around how do you build partnerships across sectors. And so I think it really starts with key things, right? Start with data, start seeing the spatial relationships, seeing where there can be projected benefits, both in economics and in health. I think there are ways in which you can link people in place bi-directionally. You can map chronic disease and see where you have the healthy grocery outlets. You can map housing costs and you can see mapping where you have heart disease. You can see about where you have jobs available and where you have higher rates of depression. These are all documented ways in which these are interrelated, and therefore you are able to solve multiple problems with the same solution if you're able to implement it. I think the other piece that I really just have to note is that it's really about changing processes of community engagement. It's important to invest in community leadership in all forms across the state, and ways in which you can really build new ways, new leaders, in order to really see an alignment around community power sharing. If you go to the next slide, I really like to talk about ways in which there are lessons to be learned. And I believe it really, when you think about sectors that have money that could be brought to bear, I think the healthcare sector can be a really important source of capital to try and do this. But it's really important to understand the healthcare business model. I think we can provide capital to build new units. We can provide capital to renovate existing housing stocks. We can also provide it to benefit not just our patients, but also our employees. And then lastly, we can provide money to pay for services. I think it's really important to understand that when we talk about our frequent users, ones in which are coming to the ED often, are using our services disproportionately to what they should be, being able to offer a housing solution makes a huge difference in being successful. And so being able to fund both a housing solution and to potentially fund the service solution to keep them housed once they're housed, I think this is a model that you will see more and more. I also really want to highlight that I believe that capital must flow to the most marginalized communities. And so I think those are ways in which you can invest in coalitions. And I wanted to particularly give a shout out to coalitions like the Mountain Plains Regional Native CDFI Coalition and the Montana Native Homeowners Coalition. These are known entities that are able to deliver results, because we understand now more and more that when capital flows towards the most marginalized, it often can have the most disproportionate impact. And then lastly, I think that it's really important to think about ways in which we can work intentionally, ways in which we can have a capital absorption framework, and ways in which we can see improvement over time. We can see ways in which we can have a shared priority. We can be able to focus on tangible products, and we can have a ways in which we can see towards system change. Next slide. So it also, I think, is really important to start to think about community development as upstream health. These are ways in which we can build new homes. We can renovate existing housing stock. We can invest in small business and jobs. We can invest in resilience. And I know that, again, it's just heartbreaking to see the effects of climate change as they're coming down in ways in which we can are dealing with them. But I think that's more important than ever for us to be able to invest in climate resilient housing and to have more housing stock, because we can't afford to lose any housing stock. I think it's really important as we think about capital to be able to implement those plans. It's not just about funding affordable housing options. It's really about funding small businesses, healthy retails and communities. It's really about important to fund community development finance institutions, because once you fund them, that is funding that is going to recycle through that community over time. And it's really important to ask yourselves, why are there systemic barriers to the access to capital right now? I will just note that the statistics have shown that for every 8 cents that a Native American has in wealth, a white household is going to have $1. And so why does that exist? Why are there differences in terms of access to capital? And how do we break down those systemic barriers over time? I think these sectors are really important because as we come together, we can build more political capital in order to invest in our larger goals for housing, climate change, and environmental investments. If I go to the next slide, it's just, there's one example that I really am proud to be part of, which is the Opportunity Starts at Home Coalition. If those that are interested and want to learn more, it's called opportunityhome.org. And this is a broad multi-sector coalition, not just with housing groups, but also with the Children's Defense Fund, with Community Catalyst, the Food Research Action Center, Women's Law Center, and many other mental health and economic justice issues. These are ways in which housing is the foundation for a stable, decent, affordable home for children, families, and communities. And so I think if you want to learn more, there's some really great bipartisan legislative solutions, both around eviction prevention and opportunity vouchers that are currently being considered in Congress. All right, I think I have 2 more slides. So if you go to the next slide, I think it's really important for us to continue, as always, to think about ways in which we understand housing and health, and we understand the underlying structures and systems that are producing differences in social determinants of health, like housing, and how those result in unnecessary health outcome inequities. And so as we start to think about it more and more, think about ways in which who has access to credit, who has the ability to borrow, who has the ability to build, who has the ability to do things, why are those structures in place, and how do we make more differences in terms of being able to address those underlying social factors, and how does that then result in the better health outcomes that everyone is entitled to and eligible for. And so the last slide I'm going to do, and then I'm really excited to open it up for questions, is I love this cartoon, and many of you may have seen some versions of it. This is from the Interaction Institute for Social Change, and in many ways, it starts first with kind of reality. And the reality is today is that some people have many more advantages in order to be successful than others. And so in this case, the cartoon is showing people looking over a fence at a baseball game. And so one person is literally standing on 7 boxes. You can't even see them in the picture. They have no problem seeing the game, and they're like way up there. And you see one person in the middle who is standing on 1 box and is getting over. And then you see another person who not only does not have a box, they're standing in a hole. And that's the reality of what we're dealing with. It's important to note that equality alone doesn't get us there, right? If you look at the 3-heighted people in the second window, you'll see that if you give them each all 1 box, the tall person looks over the fence, thank you very much, without the box. The middle person gets over the fence, and the short person is still not getting over the fence. They're the same. Equity is interesting, and I think equity is a very important concept, and one that most people are talking about. And that's where you give people what they need in order to be successful. And so one person doesn't need a box. They're looking over the fence. The middle person gets that 1 box, and that short person gets 2 boxes, and then everybody's able to see over the fence. But I'm going to challenge you as an audience, and this is where I think Montana can do it differently. It is about really tearing down the wall. And so it's not just about giving people the boxes and filling the gaps. It's really about eliminating the gaps where they are. And so it really is about addressing the root causes of inequities, the walls and the structures that are creating the differences. People can be whatever height they want. They still should be able to see the ball game. And so this is ways in which together, I believe that Montana can make it happen. A stable, decent, affordable home for every child, family, and community. And so I'm really excited. Thank you so much for having me as your closing keynote. And I really look forward to opening it up for questions. Thank you.
Thank you so much, Dr. Sandel. So many incredible examples of partnerships and really getting to that systemic and upstream level. I'm looking to see folks really interested in what your reactions are. Lots of hearts and claps, and love to see your questions as well. There was a question earlier when you were talking about sort of household impacts on childhood asthma and other health outcomes, whether you have any perspective on the impact of pesticides in rural areas and how that's impacting child health.
Yes, thank you for that question. I definitely think that in many ways, we sometimes solve one problem and create two more. And so in a lot of ways, I think the use of pesticides has been really well documented to be really not just impacting on respiratory health, which a lot of asthma is, but then it also is really really difficult around honestly neurodevelopment, right? Pesticides are both associated with brain development and respiratory development. And so I really think it's really essential for us to take into account child health when we're making those recommendations. The regulations around chemicals is really outdated. It's from the 1970s, and they've not updated those federal guidelines. And so I really do think it's important for us to have more data, being able to study the impact of pesticides. I will just give a shout out to the American Academy of Pediatrics, has a committee on environmental health. I served on it for many years. We did put out a statement around the safety and review of pesticides and chemical reviews in writ large. And there is an entire green book, we call it. It's our textbook on environmental exposures. And so if you're interested and worried about in your community, I would definitely have you follow up with the American Academy of Pediatrics.
Thank you for that. So we do have another question here. Women face structural barriers as well in regards to assets and wealth, in regards to education. This has become increasingly apparent in crises like COVID, when women who may already be overburdened with home tasks while working also have job loss, childcare, school closure. Could you address this aspect of health in connection with equity concerns?
Yeah, thank you so much for that question. I do think that as we think about structural inequities, we oftentimes, especially for children and women bearing sometimes a disproportionate impact of caring for children and making sure that they're safe, we realize that childcare has been chronically underfunded. And to an extent, you end up with real difficulties, especially during the COVID-19 pandemic, when many childcare outlets had already didn't have enough childcare, and now half of them are closing down because of not being able to follow rules or not being able to space or not being able to test or other things. I truly believe that we need to fund childcare infrastructure. Not only is it great for kids' brains, like kids show up ready to learn in kindergarten when they've been in good quality childcare, but it also is hugely relevant to women being able to be in the workforce and being able to earn higher wages. And so I definitely think as we think about this, we shouldn't be attacking it on the individual level. We really should be systematically looking at the availability of childcare. And this is where there are now sectors like healthcare or others that are starting to seek out what are ways in which we can do childcare. I will just note one other thing is that the nature of work is going to change. And in a lot of ways, there may be ways in which we start to think about, oh, you're building housing. Oh, let's put a childcare center on site. Let's finance that so that it is cheaper. Let's help people start small businesses. Let's allow people to pay a family member and use a childcare subsidy that way, because it may be hard to travel to a better place. So I think we need to get to be a lot more creative to try and address these things. And I do believe that we have to be a lot more focused on the economic justice issues that face women disproportionately.
Yeah, and Kathleen, thanks for your question. It's such a prescient issue. I think we know in Montana that when we look at our workforce, the two issues that are coming up most strongly in all of our communities are housing and childcare. So we really have to be addressing both. Okay, what about, there's a question here about whether after the prescribed housing study, has Boston implemented more upstream housing efforts or more efforts utilizing the study as a tool? And also just to note, I'm seeing all the questions in the chat. We'll try to get to as many as we can. Thanks, everyone.
Yeah.
Go ahead.
Yeah, so we have started to do a lot more upstream investing. I'm really happy to say that my hospital, Boston Medical Center, invested $6.5 million into housing partnerships as part of a community benefit obligation that we had as a not-for-profit health institution. And so we were really excited to be able to invest in an equity fund, not the equity that I just showed you, but actually a financial product to create more affordable housing, which was called the Healthy Neighborhood Equity Fund. And we actually also provided some long-term no interest loans to actually start up a grocery store in a food desert in our inner city. And then also we're able to help fund other supportive housing projects, because we saw so often that many of our medically complex individuals couldn't get into housing. And so we were able to fund 3 new housing developments. What's exciting for us is that this approach of thinking about a housing prescription as a health intervention is something that my hospital and others have started to embrace, and bringing Medicaid service dollars paired with housing vouchers forward so that we could target the most highest cost users. So for instance, in my health system, the top 3% of patients used 40% of the dollars in our health system. And so when we looked at those top 3% using 40% of the dollars, guess what? Half of them were homeless and housing unstable, and our case management did not work very well. And so this is the way in which I think there needs to be more partnerships between healthcare, particularly insurers, and housing, so that we can create more opportunities.
So interesting, on the Department of Health office hours today, Tracy Clark mentioned Medicaid waivers, and there is a HEART waiver that's being looked at through the governor's office currently. So for anyone interested in that link, we're hearing more and more about that. It's been a little bit of a long path in Montana, but seems like there are some steps being made in that direction. It's exciting. So I'm just going to do one last question, and we're going to run out of time with Dr. Sandel today, but this is a great one to close it out with. So a shout out first to the Montana Healthcare Foundation for their work that they're supporting in this space, but really looking for what else can we be doing to engage with our local healthcare providers. And I would just add my own color on this, which is, you know, in COVID, everyone, housing, health practitioners, everyone's just been nose to the grindstone with all of the work that we have right in front of us. And so being able to get into that partnership mode and find what are those avenues, what are those best practices, how can we really engage with our local providers and health systems?
Yeah, no, it's a great question, and thank you for asking it. So I do think it starts in 2 ways. One is, I think there are more and more healthcare providers really should be understanding individuals or a family's current living situation. There are great standardized questions available. The Accountable Health Communities, which is a Medicaid kind of Center for Medicare and Medicaid, there's a single 3-pronged question. How do you describe your living situation today? I have stable housing. I have stable housing now, but I'm worried about losing it, or I don't have stable housing. I'm either living in a motel, or I'm living outside, or I'm living in a shelter. And so being able to understand an individual's living situation is important. And guess what? We've even created diagnosis codes where we now will put on a bill, I saw a patient and they had an ear infection and they were homeless, because that's important for us to track, right? I may prescribe a different antibiotic, one that doesn't need to be refrigerated, if I understand that you're living in a housing unstable situation. So I think it's really important. Every healthcare provider should be using these questions and understanding it, and frankly, documenting it in the electronic record and putting it on diagnosis code so you can track it later. I think the second piece is anyone who's in the public health, housing, social services sector, ask where you're getting healthcare and what insurance you have, because it's important in your community. You know, there may be, yes, there's one community health center, you know, everybody goes there, but a lot of times there may be multiple choices. And so understanding the predominance, this is who you're working with, and asking them whether or not they have complex disease. Are they going to the ER? Are they, you know, getting hospitalized? Because if you're showing up to, say, you know, a certain hospital and you said 40% of the people that I'm serving are your patients, and they're telling me that 80% of them had an ER visit in the last year, wouldn't it be great to talk about a community health worker on site that would prevent you from having people coming to the ER? And so that data, I think, is where it starts, because you can do data, and then you can do program planning, and you can ultimately do policy work.
That is a great roadmap for us. Thank you so much, Dr. Sandel. Your energy, your incredible tools and resources and experience are so appreciated. And we're just honored that you joined us today. And we hope we'll see you in Montana in the future.
I will come back anytime. And I'm really apologizing for the crashing, but I'm really excited that you guys put on this great conference. Thank you so much for having me.
Thank you so much. Attendees, I just have a few things to close us out today. So as we come to a close, want to remind you all that our People's Choice voting will be open for just a few more minutes. If you haven't gotten your vote in, please do so. We're so excited to see who will be this year's People's Choice Award winner. We also want to announce the winners of the leaderboard and the photo contest. So the leaderboard winner is Carrie Sharp. Awesome job, Carrie. Thanks for all your participation and engagement over the last 2 days. 69,900 leader points. I don't even know what that means, but I think it's a lot. And the photo contest brought in some incredible images. The winner of that contest is Sarah Willman. So beautiful photo. Thanks for sharing that with us, Sarah. Lastly, we would invite you to provide feedback on this year's conference. The survey link will be in the chat and will be distributed via email later this week. So we really appreciate your feedback, appreciate your input. We do hope and plan to be in person together next year. So look for an announcement of dates and location to come later this summer. And then just a couple other a couple of other things we wanted to acknowledge today. First of all, to bring it full circle to our opening plenary, I think we did not get you all the link to the Montana Housing Coalition and would like to do that now. If you're looking for a place to engage upstream at the policy level, that coalition is really active right now, getting prepared for the upcoming legislative session. So that's one of many places to engage, but important one to highlight. Again, a shout out to the Montana Native Homeownership Coalition, who is our Give Back awardee this year and also presented this year and was acknowledged in Dr. Sandel's presentation as a place where we can really work on equity and making sure that housing opportunities are available for all. And then lastly, we want to again acknowledge the flooding and the incredible environmental impacts and changes that people are experiencing across the state. I know many people are looking for ways to support rescue and resiliency and cleanup efforts, and the Red Lodge Community Foundation is one organization that has stepped up to accept donations. We're hearing that there may be flooding in the Flathead to come, so continue to keep your eyes out on those communities and supporting their efforts. I'm sure there are other organizations that are coordinating efforts, and we'll continue to share those through our various networks, but the Red Lodge Foundation link is here in the chat for everyone as well. And great, thank you, Robin. You've added one for Park and Madison County. So a lot of great and continuing work for us, many challenges, but also hopefully a lot of sources of hope and inspiration that have come to us all over the last couple of days. You are an incredible group of passionate, dedicated, skilled people, and it is absolutely a pleasure to be in partnership and in work with you across Montana. Until next time, take good care, keep up the great work. Thanks again. Bye, everyone.